Welcome to the Healthcare on the Move podcast, your gateway to understanding the future of clinical mobility. We bring together healthcare executives, IT leaders, and technology innovators to uncover the strategies that turn mobile technologies into powerful tools for patient care. Each episode uncovers the real-world insights that are reshaping healthcare technology. Now, here is your host, Myron Wallace.
Welcome to Healthcare on the Move. I'm your host, Myron Wallace. I'm excited about today's conversation because my guest brings both strategic lens and real-world operator mindsets. Dr. Alan Moore is with T-Mobile, and he's been deep in the work of helping health leaders apply modern connectivity and innovation in ways that actually stick. Dr. Moore, thanks for joining me. Before we jump in, for anyone meeting you for the first time, how do you describe what you do and what you're focused on right now within T-Mobile?
Oh, good grief. What I do sometimes requires way more explanation than what we have time for here. But I think the easiest way to say is that I'm looking for that intersection between the contemporary pragmatic technology focused on what can be done not only now, but also planning for the future, and also those areas in care needs where the care teams are trying to develop applications to improve the outcomes. So it's that intersection between what really needs to happen in care now and the pragmatic solutions that we have that can be built on a foundation that can grow as the innovation matures.
Awesome. Well, let's start simple, Dr. Moore. When you look at healthcare today, for our guest, what's the big misconception that leaders looking at mobility and connectivity solutions think about when they're looking at these advanced solutions?
I think the biggest misconception is one size fits all, right? I think that we have to reimagine, we have to rethink what we thought was possible. We assume that this device is doing all it can do, and it's not, right? So we've been trained for the past 40 years to use a device as the carriers instructed us to use the device. We've been designing networks, local area networks, wide area networks, et cetera, for the use of this is mobile, this is wired, it's a large device, it's not going to move anywhere, we're going to plug it in. This is a device that's in clinical care environment. This is a telemetry device, but we never think about it holistically. We think about this is the device, the carrier asks us to use this device for talk and text. And that's just what we've been relegated to. We've got applications on here, which are fantastic, that are generated and developed by outside applications. But we continue to think about the application in the connectivity space separately. We continue to think about the application space as being limited on a particular device. So if you start to blur those lines, if you start to look where you can enable clinical care inside the four walls of a hospital, of a provider space, and then outside those four walls in the same way, it takes a new mindset. And it's not hard, right? I'm not saying that we have to spin the world a different way here. I'm saying you have to explore, you have to get in there, you have to try things that are a little different. And we've got a couple of labs. We've got a clinical lab that we're in the process of standing up with a premier Southeastern Academic Medical Center. And then we have our traditional technology lab that's in Bellevue, Washington. So I think that the large fallacy here is that we continue to think about the limitations that carriers have imposed upon us. And we really need to be asking the question, what's going to make a change in the outcome? What is it that I really want to do? How can I connect these different systems that I have with this device that I've had for a long time? I think that's the biggest fallacy. I think there's room for improvement there, but we got to think differently about it.
No, it brings up an interesting topic. When you look at the device, so many of the devices get rolled out by IT. One of the missions that ProMobic focuses on is exactly what you touched on, which is one size does not fit all on the device. So that really resonates with me and some of the customers we've been talking with, specifically most recently. When you look at the connectivity pathway, let's talk a little bit about the micro-slicing piece and what that actually means for the care environment. How does T-Mobile think about micro-slicing, and what actually is micro-slicing to educate our our audience?
Sure. Microslicing is really available in the 5G core natively. So I think that's really interesting that everybody can give you something that says 5G in the side window up there. But the reality is you're running into a bottleneck there. You're tunneling in other carriers this specific use case application, low latency, low jitter, a direction to a specific cloud, right? I mean, cloud compute is just a group of computing devices located in a particular space, whether it be East Coast, West Coast, down the street, AWS outpost in your basement, whatever it might be. The 5G environment that is standalone core, which T-Mobile is the only one that can offer the standalone core, is natively going to provision these slices, and these slices can provide for video, which in the Formula One and the PGA recently, that video was transmitted over a photojournalism slice, which provided those capabilities and that packet adjustment. There's a lot that happens between the time my camera receives this image and it's transmitted downstream. So the network is in touch with all of those elements along the path, and we can make sure that you get what you need: frame size, packet size, windowing, direction, connectivity. All of those things can happen based on what your needs are, right? So that micro slicing can change based on what you may be looking for the application to do. Think about this. We're trying to solve a physics problem here, right? Everybody wants super fast compute, nodal latency, 10 milliseconds, give or take, to a cloud space. Well, how do you overcome the limitations of physics? Because you're only going to travel so fast regardless of where you're going. I think about in the healthcare space, while you and I may be having a same space encounter, and there's ambient listening that's going on either on a tablet, or maybe the room has been mic'd and you're now recording this in the cloud. And then we're going to use a little AI to go back and parse segments of the conversation to make those transcriptions. And then the transcriptions are going to feed some sort of inference model, et cetera, et cetera. All of that starts with quality in the recorded environment. So, it's happened to everybody 100 times where you're driving down the street and you say, hey, give me directions to the nearest X. And it comes back with something that you didn't ask for and it did not understand. That's because you got a physics problem. When you dictate, you're dictating into the cloud, not to the device. It's recording and taking that signal that we all use, our voice, and it's making it a digital pattern. And then it's matching that digital pattern up to something that you have requested. When it gets garbled from the time it enters this device until it exits to the cloud, then you're not going to keep as much as you actually intended. So we can micro slice a healthcare facility so that you get low latency, you get low jitter. That means the conversation is going to be recorded in the Scribe software just as you had intended. We're in the process right now of measuring that. We're taking 10,000 words of clinical text in multiple dialects, and we're going to prove that the micro slicing that's available to a 5G standalone core actually improves the outcomes of the transcriptions. Because if you have to hire someone to go back and look at the transcriptions from a same space encounter, have you really gotten the productivity out of that technology that you expected? Probably not. So if you can keep more than you would have to go back and clean up, then good for you. You've gotten the every ounce out of that productivity. And again, because we have the lab and we're standing up the clinical lab, those environments are going to come a lot faster. Those experiments that we can measure and then deploy with some degree of evidence-based study behind them.
Yeah, that leads me to something else that I think would be interesting to touch on is healthcare is underneath a lot of attacks these days from a cyber resiliency perspective. And with T-Mobile's network, with the micro slicing, there's inherent security that comes with that you just cannot get with Wi-Fi, right? So what does that look like from that point of view?
Well, I want to break this down into two pieces. One, If you're using security today, you're tunneling, right? If you're not on the 5G core network, standalone core network, you're tunneling that service. So if you have a VPN tunnel, you have a certain amount of overhead, regardless of how large that packet is, you've still got a certain amount of overhead that you have to give up. And I think we just assume that, oh, well, that's just the way it works, right? That you always got to have VPN tunnels to protect your data, and those tunnels are going to have overhead, and therefore you're not going to get every ounce of productivity out of your network that you normally would have. So if you set that aside for a moment and realize that the 5GSA core is inherently as secure as wired, and in some cases more secure than wired and tunnels together, then you start thinking about the opportunity to deliver this traffic a whole lot faster without the overhead. From a cybersecurity standpoint, I was actually looking at the Office of the Inspector General data breaches this week, and it's not a question of if, it's a question of when, right? So you want to mitigate as much as you can mitigate. But when you start talking about running security on LTE devices, because I think about social workers, I think about first responders, I think about community health workers. They're in the field and they're using these devices. They're connecting back to the host just fine, but they're using these devices with tunnels. And when those devices are lost, misplaced, captured, stolen, breached, etc., you're going to run into problems with the OIG, because for any breach that is more than 500 records, you have to report that. We're working with a client right now that had an assessment of $198,000 because a clinical health worker misplaced a tablet, and that was problematic. If you had been using some of the technology that we can deploy for community health workers, there would not have been an issue there. So I think when you start talking about the inherent nature of IT security, we have a significant presence in the governing bodies in the IT security world, especially in healthcare. Heather Goodnight is just amazing when you get to understand what the bad actors are really intending, and how much they want to pull away from your trusted resources, right? The security measures that LTE have had are 11 years old. So if you think about the last time the LTE standard was updated, it was about 11 years ago. The 5GSA standalone core is contemporary, and those IT security standards are very strict and certainly very present in the T-Mobile network.
Isn't it funny how talking with customers, that are deploying these complex networks, hospitals are inherently complex because of the amount of data traffic that you have. You have real-time imaging coming out of diagnostics lab. You have all the clinical input going on from the EMR perspective, the alarm systems, all these things are taking up network traffic. And, you look back to like the way Cisco and other manufacturers who originally built the enterprise network in these facilities, the holy grail was to build the converged network. But now we've stepped away from the converged network and said, okay, it's maybe time to consider different alternatives so that we can have that segmentation for continuity. Because if ransomware hits these facilities, they shut down a lot of those network access points to data, and meaning not network access points in the sense of Wi-Fi, meaning network access points in the conduit pathways to the data systems that exist in those four walls. And you and I both know that, there's constantly emerging reports that threat actors are on the rise. And now that we've entered this space of AI is the one propagating these types of threats against these health systems. So it's become a paramount issue for hospitals and customers of ProMobix and T-Mobile to think about, how do we actually solve these issues so that we are secure, that we're not going to have these types of data breaches. At the end of the day, people want access to that information, because where else can you find personal information, PII, that contains, social security numbers, date of birth, all the identifiers. It's a treasure trove, for the bad actors that are out there. So it's important that we think about these things. And I know, T-Mobile has been focused on that as much as we are on educating our customers. Thinking about, like these segmentations of network and security and all these things, it's not cheap to deploy these types of solutions. So with some of the new governmental bills that's been passed, like how's the impact of that on these types of initiatives, and what's T-Mobile specifically able to do to help modernize the health infrastructures that we have in not only North America, but I mean, you're also expanding outside of North America in some of your governing bodies. But what is T-Mobile actually doing?
Yeah. So I appreciate you hitting on that. It's funny. We were desperate to convince regulators that technology in healthcare could improve outcomes. And COVID was an awful reason to advance that. But there's things that we're doing now that have become mainstream to the point where we're seeing significant funding in some of those concepts. So the One Big Beautiful Bill that passed in July, that I guess is the One Big Beautiful Act now, Section 71401 contains language for rural health transformation. So the number one, and there's 7 criteria in that bill, the number one piece of that legislation was to address how do you improve access to care. So if you think about the access to care piece, T-Mobile is fortunate to have some wonderful technology, and I don't want to go down to the bits and bytes level, but our service travels a little further because of the technology we have. So in that environment, to reach rural constituents, those waves are going to help bring that patient into a remote encounter in the way that a non-standalone environment or a shorter wave could do. So I love the fact that some of the things that we're looking at now is improving the access. Of that 7 criteria, you also had where can you lay the foundation for technology to help support healthcare even after the funding expires. And I think some of that is, I think about the state of Mississippi, right? So they're looking at taking their funding that they've requested and building out their health information exchange so that every doctor from South Haven to Biloxi can communicate over the same network. So I think that's really important, because when you start talking about the collaboration of these care teams, if you're on an island, it doesn't help the outcome there. So I love the fact that these things are becoming mainstream. And what that tells me is that the thinking that we've been doing for years and years about how to get funding for technology in healthcare is coming to pass. So what that tells me is that we need to be thinking differently. So now we have some funding, we have some acceptance. How do we think differently now about the use of devices in clinical care? And again, it goes back to what have the other carriers done that have regulated us to use this device in the way that we use it today? That's stinking thinking. So stop. Let's talk about the outcome. Wouldn't it be great if the patient could do X? Wouldn't it be fantastic if the social worker had access to Y? Wouldn't it be great if the physician could go from the basement to the 7th floor without having to log in again? How much fatigue would we save on clinicians if we didn't have to continue that exercise of update, login, update, login? So I think that these networks were built for purpose, and they've done really well. But I think that may be a little behind us, or if it's not quite in the rearview mirror, it's certainly up to where we are, and we need to be thinking differently. Does that answer your question?
No, that's perfect. And we recently were at a site doing a discovery. One of the things that we focus on is exactly what you hit on about going from the basement to the 7th floor, having to deal with the log in, log out process, and the cognitive overburden that the care teams and support service lines deal with on a day-to-day basis. And it's always amazing. We think about these problems, we hear about these problems, but when you go observe them, it sheds a different light on the problem and the opportunity to come in and actually have an impactful engagement with care teams to say, hey, there is a path to simplicity.
Right.
and what we refer to as caregiver delight. We want people to utilize the technology and not fight it on a day-to-day basis. And I think it's really important that we are the stewards of technology as T-Mobile, providing the conduit and the connectivity and the device manufacturers and the consultants and the EMR applications. We contribute a lot to the fatigue and cognitive burnout that care teams deal with. And you look at statistics, there was a statistic published that 31% of the care teams are looking to transition out of the roles they're in because there's now a shortage of care team members. And a lot of it is burnout of systematical processes, but then also the burdensome of having less staff creates more issues on the cognitive side for the nurses. So there's opportunities there to come in and simplify this.
I think too, and I just want to add that, if I've got a nurse and I'm looking to move locations, they're going to be looking for a magnet organization. So the magnet organization, one of their criteria when they interview the nurses for their particular providers, one of the criteria is my employer cares about me. And it's clear in some of that data that shows that when you have technology that works and it doesn't hinder, those scores are a little better. So you start talking about providers and headcount. Consistently, headcount and cost of operations are number 1, 2, or 3 in the American College of Healthcare Executives yearly survey. And when you start talking about that headcount problem that we have, if you can enable that score and increase your opportunity as a magnet organization to attract new nurses, that's just one piece of technology that maybe you hadn't considered. And it's certainly hard to put that on a balanced scorecard against a Wi-Fi or a wired.
It's so true. The technology aspects of coming in, we often talk about if you can come in and begin your shift and end your shift with ease, you're not likely to consider going elsewhere if there's opportunity. And it makes a big difference. I mean, it's amazing at shift change what that looks like in the units.
And there's a patient safety issue, right? If I know that it's going to take me an inordinate amount of time, or I've got a complex process to go through, if I know that that's the case, am I actually going to bring it up? It's 5 minutes till the top of the hour. I've got to get Joe from daycare. Am I really going to spend the time to talk about patient safety issues that might have popped up because I've got technology that's not playing well with me? Probably not. So I think there's a patient safety issue in there too.
So this has been awesome. When we think about, the next chapter, connectivity, one thing that I wanted to make sure we discussed is extending the care environment. Hospitals are trying to figure out patient throughput. How can we transition patients from the 4 walls to their home and still provide care inside the 4 walls? So what does that look like from the connectivity pathway, with T-Mobile's network and remote patient monitoring?
Yeah, I think it's important. The devices that we talk about, those applications are built as cloud native. And if you don't have a good experience in the connectivity, you're not going to have good uptake on the use in the field. So I think about the devices that may be Bluetooth enabled. I'm just going to give you a device. You're going to take that home. You're going to connect that to your home Wi-Fi and away you go. Well, you're assuming that I'm going to connect that, or when the battery dies, I'm going to know how to reconnect that, or some of the troubleshooting that happens, in the CMS world, you get paid twice a year for educating the patient on how to use their device. I think that's important. I think the reimbursement portion, I think the reimbursement portion of the remote patient monitoring makes it very exciting. I think that just to capture data without some inference or some meaning doesn't help a lot. So if I'm going to record the data from a remote patient as a provider, I'm not going to look at that data every day. It's not going to be something that I have time to do because it doesn't pay. I need some actionable information. So if I have the remote patient monitoring device attached to that application, which is talking to the cloud reliably and securely, fantastic. I'm going to be able to generate those reports with accuracy, and I'm going to be able to represent the change in treatment to the patient, and then that's going to build trust. So I think, again, it goes all the way back to the connectivity in the way we interoperate with the applications and the applications to the cloud, wherever that cloud may be, whether if it's far edge or near edge, et cetera. I think that the uptake from the patient's perspective is it has to be reliable. You have to delight the end user in order to create the adoption. And I think when you've got a superior standalone network that can handle congestion, doesn't result in bottlenecks, has a tremendous amount of IT security wrapped around it, I think then the adoption is going to go up, and then that adoption we would hope would represent better outcomes.
So where do you think this is ultimately going? With the connectivity is a big piece of it. The device is the secondary, and the third is the experience. Where do you think this is ultimately going, technology wise and caregiver wise?
It's all about informed, and I would suggest that one will inform the other. So I think that informed care is important. You've got a foundation of information that has to happen, whether you're in the hospital, in the four walls, at discharge, right? So, when's the last time you picked up an instruction book for an application, right? We all learned how to use Facebook and TikTok from picking up our device, and it was intuitive, and we were able to pull together some very cool things. It's the same way. So if you think about discharge instructions, the way that we're going to be able to make those available to patients, that are leaving the four walls, that are now going to be instructed to do things when they get home, I think that's important. If you think about hospital at home, the Hopkins initiative from years and years ago, that's doing very well. It's growing. CMS endorses it. And the number of clinical care organizations that are participating continues to grow. I think home health, not only as a choice for people who don't want to be in a hospital or providers that don't necessarily agree this is the best place for them. Great. Home health is a fantastic application. It's billable. A lot of the providers own home health organizations now. And I think that's fantastic. I think because the technology enables care like that, I think it's going to continue to elevate where we take care. You've got a great product that I've seen in action, the slips and falls, right? Where you can identify a user in their environment, whether it be at home or in the hospital room or in psychiatric ward, et cetera. And you can use that device to predict with AI, hey, I see that Alan shouldn't be getting up from a seated position, but I'm forecasting based on the behavior that the tool has learned from 100,000 witnesses of people getting up from a seated position. I'm going to forecast and alert my caregiver that Alan's fixing to get up from a seated position. That's important because I shouldn't be, for whatever reason. I don't want the slips and falls. It's expensive when you're in the hospital. And if you get a readmit, it's expensive if you're at home health. So how do we bridge those two? I think computer vision, I started out the conversation with, I think that the enabling technology allows us to be there when we can't. And I think computer vision is just a natural extension of that. Yes, we've got privacy issues, but we do a great job of obscuring the body, the face. We boil those images down to something that we can understand from a computer vision platform standpoint, and we began to make inferences. And I think that the computer vision applications are going to be much more widely developed than they are now. One, I think because of the headcount, and two, because the technology that's needed to put them into practical applications in the home or in the hospital. I think that technology has already caught up, and we're just primed for some really good computer vision applications. That's what I'm thinking. And at some point we'll get reimbursement for those applications.
I think it's interesting, the impact of AI. When AI first started to make its mark in the marketplace, there's still data being gathered, and we have treasure troves of empirical data, but really haven't figured out a way to take that data and do a lot with it yet. So to the point of what you were describing as our Alero active fall prevention capability on the slips and falls side. I think it is powerful for all health organizations to look at that because, patient safety issues are the number one initiative a lot of organizations have right now. And specifically, data that we're going to get from that in 10 years, even maybe less, depending upon how we can build out these data sets from historical data we have. We're looking at a different care environment in the future, and connectivity being the staple point of what needs to be the most solid and secure because everything runs on a connectivity pathway and all these devices need to intercollaborate. So,
well, it's not just the devices that need to intercollaborate, right? How many times does the social worker speak to the primary care physician or the hospitalist, right? How many times do you really get that full collaboration if you have AI in a well-connected device that's taking data in that's pure and trusted? Now you get this broadcast of information that's circulated between the primary care and the hospitalist and the social worker and the community health worker, et cetera, et cetera, et cetera, that the AI are making some inference that you wouldn't necessarily have, and you're able to broadcast these findings to a larger care team that can now have a greater impact.
100%. I think it's definitely, the right way of looking at it. The one thing I was going to leave our guest with is, where do you think, if I was in the shoes of a CIO or CNO at the leadership level of these hospitals, what should I be thinking about? What should I be considering, going into really not even just 26, but beyond 26? What would I want to have on my roadmap?
I expected this question. And we see it, right? CNOs, CMOs, again, they've been trained, hey, it's talk and text, or you've got some applications from a third party. I think that they have to be bold, and I'm not saying they're not, don't get me wrong. I think they have to be bold in asking the hard questions and exploring, right? I think that they have to say, I wonder if we did X, would that have a change in the outcome? If we dialed in telemetry to work with a service Y, would that have a change in the outcomes? I think about telemetry, right? Telemetry for one particular DME, for one particular manufacturer is going away. So how can you interface those devices that you have relied on for 50 years to now talk to devices that are novel in scope, right? Devices that are currently being certified and tested. I think you have to say, who are the partners that can bring me into 26, 27, 28? How can I get the partners to help remove risk? Right? So I have an idea. I want to kick the tires on something. What is that something? Great. Talk to a partner like Promobix and T-Mobile, and let's take whatever it is you want to do. Let's put it in our clinical lab. Let's run some sort of institutional review board for bedside technology and see how that's going to impact the patient, so that you don't have to be the first. You don't have to go with this and say, let's deploy this in the field and assume it's going to do no harm. Let's put this through the rigor of some research and actually prove, hey, this is evidence-based medicine, just like you would find in pharmacy, that we know because we've measured this at bedside in a controlled environment, this will help us dial in a 33-degree change for improved outcomes. So I would ask that the CMOs, CNOs, CIOs, the presidents of the organizations actually ask the hard questions of their partners and say, can you help me understand how we get another ounce of productivity and better outcomes from your technology by putting that in a working space or in a lab space?
That's great. We all know there's lots of fragmentation in healthcare, and there's a big initiative to simplify not only the clinical workspace, but the vendor workspace that surrounds the technology that these organizations are employing. So we're trying to figure out that pathway. And I think this is a very exciting time with AI, the ability to have the connectivity to extend patient care outside the four walls and setting up these remote patient monitoring. So we are being better organized in the way we provide care it's a different chapter ahead in 26 and beyond as we look forward.
And what I'm asking of the CMOs, CNOs, et cetera, that's not an expensive proposition, right? If there's something that you would like to try, great. Let's talk about what tools we have, what tools you have. How can we bring those together? We're not talking about a large expense here for organizations that are traditionally strapped.
Yeah, 100%. When you look at, how do organizations think about trying out these types of technology? What does that look like? If I'm an organization, I'm really curious about A&S. I know you have a lot of case studies where this has been deployed so far, but how would I think about trying these services? What does that engagement look like as we look ahead?
Well, I think it all starts with a phone call, and I'm sure you'll have links here in this podcast in order to get to Promobix. And as we are tied at the hips together in clinical care, I'm glad to make that phone call with you to have that conversation. It all starts with a question, right? Can we? What if? What does it look like if we? Right? Let's start there, and then talk about what the technology can enable. And I think that people will be pleasantly surprised that their previous thinking of, hey, I've got a device on my hip and I can only do A, B, or C. You can now think broader and start talking about very specific opportunities to improve outcomes. But it all starts with a phone call.
No, this has been great. Dr. Alan Moore, I appreciate you coming on the show with me today. And this has been a great discussion. Look forward to coming back, and hopefully we'll be able to point to some other use cases that we've defined in 26 together and build a prosperous future together.
I'd love that. Absolutely. Let's go forward in the new year and find some great solutions that are going to improve the outcome.
Awesome. Thank you.
Healthcare on the Move isn't just a podcast. It's a movement transforming healthcare through collective wisdom and innovative thinking. Each episode challenges listeners to move beyond passive understanding to active engagement in reshaping our healthcare landscape. If today's conversation sparked something within you, share your insights, subscribe, and help us drive meaningful change. Because transformative healthcare happens when we move together.